Thank you again for having me up here. So I'm going to talk about function MRI, fMRI, and then how we're using it for presurgical brain mapping. So all of pretty much the fMRI that we do nowadays is based on this blood oxygen level dependent contrast. Dr. Ogawa in 1990s, I think, he discovered this phenomenon. He won the Nobel Prize for this. Essentially what he found out was that there is difference in appearance of contrast depending on how much oxygenation there is in the vascular system. So if you provide mice with 100% oxygen, then you don't see any of the vessels. But at a usual rate of 20% of oxygenation, it's still doing something. At 20% oxygenation, which is more typical, right? You actually see the blood vessels. So I learned from my last lecture. I put arrows and everything now, so you can see it. And then so this phenomenon of bold effect. Let's say you have a neuron that is active, right? And you have the blood vessels in there. And so the oxygenated hemoglobin, which is bright on bold imaging, you saw that in the beginning. I'll just replay that. In the beginning, they were like, a little bit more than the deoxyhemoglobin, right? So deoxyhemoglobin is dark, oxyhemoglobin is bright. Now, when the neuron is active, you would think that because of utilization of oxygen, some of them will convert to deoxyhemoglobin. So now you have more deoxyhemoglobin than oxyhemoglobin, yes? So is that how bold fMRI works? Yes? No? No, that is not how it works. Unfortunately, we have to make things complicated. This essentially shows why that doesn't happen. So I made sure I put a lot of arrows this time so everybody can see what I'm talking about. So the purple arrow, no, I'm just kidding. So what you see here is blood flow on the top. Okay, between the left and the right, you see blood flow. And then it says resting, stimulated, and change, yes? So at rest, they're doing nothing. In the stimulated phase, they're looking at a visual checkerboard activation. And so on the top row, both of them shows blood flow and how it changes. So what it's showing is that on the red circles, they're showing that between resting and visual stimulation, there's increased blood flow. That makes sense. More blood needing to go where you need to use your brain. You look at the bottom left, your metabolic rate of glucose utilization is also increased. So you're using more glucose, which means that when you're active, you got more, glucose activity, metabolic utilization of glucose. So now you see the difference in that yellow circle, right? The third yellow circle. When you look at the bottom right, which is the metabolic rate of oxygen utilization, which is the blue circles, you notice that there's really not that much difference between when you're not doing something and then when you're actually doing something. Maybe there's a little bit of difference, but you don't see a lot of the red stuff in the change, yes? So another way of looking at this is using PET. Blood flow during a visual task increases, glucose utilization increases, oxygen utilization doesn't increase. So what that means is that if you have more blood flow, but then you're not using that much oxygen, then you're getting more oxyhemoglobin. Yes? Does that make sense for everybody? So not that much oxygen being used, but you're getting a lot of blood flow inside. So that's why oxygen availability increases. So in essence, what's happening is that when your neuron is active, you got your oxyhemoglobin, you got some vasoreactive things going on. Now, you get a lot more influx of oxyhemoglobin, and therefore your signal actually increases on the fMRI, okay? So there's a baseline amount of deoxyhemoglobin and susceptibility, but when your brain is active, a lot more oxygen comes in, and oxygen here is bright. So another way of looking at this is that brain activity, instead of causing oxygen depletion and then you want more blood, it actually does the opposite. Brain activity causes blood flow to increase, and then that's why you have more oxygen in your local microvascular environment. And you can actually model this and say, okay, well, you're looking at your nerve activity and then the change in the blood flow that occurs. And it's not immediate. It doesn't happen like in microseconds. It happens after several seconds. And that is the top image over here. So what happens is after a few seconds, your oxygen goes up and then it comes back down. A little bit below baseline, and then eventually it'll go back to baseline. But the point is that there's a little bit of a delay before your oxygen flow goes up when you do an fMRI experiment, and then it'll go down. But this is the general shape of what you might expect when a brain area is active. Then that's your blood flow and your oxygenation. That's what it should look like. Okay? So after that, now we got to go back to math. No? Okay, no. I will make this super simple. All these fancy terms you don't need to know. All you really need to know is that when you look at an fMRI experiment in real time, do you see the gray flickering? No? So I can zoom it, yeah? So if I zoom it, this is a real fMRI study that we did, and you see there's some gray, going up and down. It kind of looks random, yeah? But let's say you take one of these voxels and say, okay, what's going on in that voxel during this fMRI task? And you can do it if, again, bright is whiter, and then the dark is gray, yeah? Darker gray. If you start imaging this at every acquisition, then you can kind of lay out your signal for that one particular voxel. So the first time you acquire the image at TR of 1, you have that amount of brightness. Second time, it might become a little bit brighter. Third time, it's a little bit brighter. Fourth time, So each TR, this is every 2 seconds we're imaging. That one voxel, this is the change in how that specific voxel looks like in terms of its grayscale. And you remember that hemodynamic response? I said that this is what the blood flow should look like if that brain area is active, yeah? So let's just split that into TRs, 7 different TRs, okay? And then now we're going to say, okay, the first TR, the blue is really low, so it's dark. The second TR, it's a little bit brighter, but it's still kind of low. Third TR, it should get brighter, et cetera, et cetera. So all this is doing is it's saying if that brain area is active, then it should have this kind of curve. And if it has this kind of curve, then the signal should look like this after time, yeah? So now we're just going to match it up and say, well, TR 1, 2, 3, 4, 5, 6, 7, how close is it? How close is your actual signal to what you expect the signal to be when your brain area is active? And so the red shows your actual signal. The blue, which is the column on the middle, grayscale, that shows the signal that it's supposed to be. And in this case, it looks like, there's some noise in there, but it's following the pattern that you would expect for an area of the brain that's active. And that equation, all that's really trying to do is to minimize the difference between the red and the blue. And so it's going to find areas of the brain where there's a very little difference between the red and the blue, and that's going to be statistically the area of the brain that's related to that task that you're doing. So practically speaking, what happens is if you take an fMRI, raw fMRI data set, and you put a crosshair anywhere, then you have that waveform, which kind of looks like random. It doesn't seem to make any, organization, right? I go one voxel lower, it still looks kind of random. I go one voxel lower, still kind of looks random. More randomness, and then right next to it, suddenly you start seeing this. So now it's going up and down, conforming to that blue waveform that we saw, because we do on, off, on, off, on, off. We repeat this task multiple times. So this would be considered a voxel that is actually related to the task because it provided the blood flow that you expect. And then same thing here. Right? So blue is what the blood flow that you would expect, and then the red is the actual blood flow of your brain, and then it's just trying to find out which one is similar. And practically speaking, what happens is that here you see on the crosshair a brain tumor, and then you can statistically determine like, okay, all these areas that were related to that change in blood flow, we're going to start putting colors onto there. And this one was a language experiment, so there's Broca's activation and some other areas. But the major clinical applications that we have, we do a lot of motor mapping, so trying to figure out where your hand motor activation is. We can do foot motor activation. We can do orofacial activation. So you put the person in the MRI scanner and you tell them, move your hand, and then we try to find that waveform. or move your feet, and we try to find that waveform. So language mapping, for example, you can nicely get all the blue areas of activation, which is Broca's activation, and then the red, there's a green above it, which is actually a white matter tract, but underneath the green there's red, which represents Wernicke's activation. So in fMRI, when we use it clinically, I have some research things going on too, but clinically, we use it for two applications. One is brain tumor, and tumor could be any lesion of the brain, really. It doesn't have to be like gliomas, but any kind of brain lesion. And then epilepsy is another big reason why they want to do fMRI. Primarily for epilepsy, they want to look at language lateralization. For brain tumor, they actually want to see how close your activation is to the actual lesion. So language mapping, we can try to figure out primary language regions like Broca and Wernicke. We can try to lateralize language because right-handed people tend to have strongly left-sided activation. Left-handed people have about 50-50-ish. So it's not strongly on the opposite side, it's just a much bigger mix between left and right lateralization. Motor mapping, we can do, as I mentioned, hand activation, foot activation, orofacial activation, you can do toes. And visual mapping is basically a checkerboard, and then you can try to find out, how your visual cortex looks like. The difficulty in language mapping and why we actually do this is because motor cortex, you can kind of tell most of the time where the motor cortex is unless your anatomy is kind of funky, right? So neurosurgeons sometimes want to know where the motor cortex is, but 90-something% of the time, I can tell them where the motor cortex is without doing fMRI. Still, they feel a lot more assured that if we give them activation maps, then they know exactly where it is because they can overlay those images into their neural navigation system. And then as they're doing their surgery, they can see what things they need to avoid. Language is a problem because it's much more variable across individuals. So what this is showing is that you see a lot of percentages, right? This is intraoperative recordings showing how many subjects had speech arrest when you stimulate that particular area. And the issue here is that you notice that the most you get is like 20-something%. That means that only 20-something% of people have an overlap for that one particular spot. When you stimulate it, they get speech arrest, which means that it's much more distributed. For everybody, your language regions tend to be a little bit more variable. The good thing about fMRI is that lateralization is actually pretty good. So there have been some reports already, a bunch of reports. So when you compare it to WADA testing, it's very, very accurate. So we can use fMRI to lateralize which side language is on. And this is very important to epilepsy surgeons too, because, and even brain tumor surgeons, because if there's a lesion on one side, and then you tell them that the language is lateralized to the opposite side, then they can just go cut whatever the heck they want, and then, not worry about language too much. And Dr. Petrella, who was once my former mentor, he had this really nice study in radiology saying that this fMRI actually changes clinical management because in some cases where this pre-fMRI plan, the important thing here is no surgery. So they initially tried to figure out, based on the MRI, would the surgeon do anything? And the surgeon said, no, I'm not going to do anything because this is too close to regions that are important, like the inferior frontal gyrus or posterior superior temporal lobe. But when they showed the fMRI, 5 of them converted to having surgery done with awake craniotomy. 2 of them, they ended up biopsying because they could use the fMRI information to say, okay, you know what? The tumor might be a little bit separate from regions that I am really concerned about, so we might as well do the surgery and avoid damaging critical brain regions. So, second half of the lecture, I just wanted to show some few cases, of practical applications of this kind of stuff. This is a 20-year-old with intractable seizures, not first-time seizures. This one is interesting because the primary language of this person was Spanish. So she grew up speaking Spanish, and then she learned English in high school. And then when I interviewed her, she actually had a decently strong English accent. So, I could tell that English was not her primary language. And the MR arrows show that there is a lesion in the right temporal lobe, yes? So on the red is the temporal lobe, and then anybody know what the blue thing is, anatomy-wise? Who won that award? What's that part of the brain? Yeah, I heard it. Primary auditory cortex, Heschel's gyrus. So, I'm sorry? Oh, sorry. So, it's primary auditory cortex. So this is a Heschel's gyrus, yeah? And it's right in front of basically the it's along the superior temporal gyrus, and it's right behind the posterior insula. And then the yellow shows that this lesion goes all the way up to the margin of the ventricles, so some kind of heterotopic abnormality of the brain. And when we gave contrast, there was a little bit of, it's really hard to see here, but there was a little bit of like funny enhancement. So we thought, okay, maybe this is like a DNET mixed into some kind of heterotopia, which can happen. And the other image shows coronal image showing superior temporal gyrus in red, and then the Heschel's gyrus in blue. Another image showing Heschel's gyrus, right? That little nubbin on the top of superior temporal gyrus. So we did our fMRI in English and Spanish. And essentially what we try to do with our fMRI, because fMRI is actually a relatively noisy test. The signal difference between when you're not doing anything and then when you're actually activating your brain is only like 3 to 5%. And so you have to do these over and over again. And even then the signal can be kind of noisy. But what we like to do is we'd like to do multiple different tests to make sure that they all point to the same specific focus. So in this case, we did listening comprehension, reading comprehension, basically a bunch of different types of English tests. And the circle shows convergent activation. So the blue, light blue, and then the magenta pinkish color. They show that in 2 different tests, they both had activation in that area. So I'm pretty confident that that area is actually important for language. And then this shows that on the left side, you have superior temporal gyrus, gyrus activation, which is Wernicke's. And then on the right side, you don't see anything. And the axial image shows the same thing, right? Now this is kind of bizarre because usually for people that are bilingual or multilingual, your primary language is more lateralized, and then your secondary language or tertiary language are more distributed. But this person actually had the opposite finding. So in Spanish, when we did Spanish specific tests, she had both Wernicke's activation, basically Wernicke's activation on both sides, as is shown in the light blue, convergent activation, right? You see the light blue dot and the red dot, that's on the right side, and then you see the same thing on the left side. So what they decided to do for this one, I actually don't remember what they decided to do on this one. I think they did not do surgery on her. Yeah, and then they were just trying to do medical management. And then, I talked about DTI before. So another reason why they didn't do it is because one of those nodules deep down, if they wanted to take it out, it's so close to the optic radiation. So the white arrow, the white arrow on the left side, I shouldn't have mixed the white, shows a little nodule, and then the red arrow shows the optic radiation. So they don't want to screw around with that. Case 2, another case of seizures. And then this is the one that you saw before as well, intractable seizures. So there was a cavernoma of the left post-central gyrus, yes? And again, the arrows show classic findings of a cavernoma. In the post-central gyrus, there was one that was a little bit deeper down. There's one in the periatrial white matter. And I actually asked the surgeon, why exactly do you need fMRI for this kind of stuff? Because it's not, we know it's not in the primary motor cortex. I know that it's not in a language-related region. And his response was, well, my access to the lesion, if I need to get into there, might be affected by what's around it. So I was like, okay, we can go ahead and do your fMRI. And we did a hand motor task just to make sure that, we knew where our motor cortex is. And this works better when you have, I shouldn't say works better. It's more valuable when you have variant anatomy, which can happen too, and then you can't really tell your landmarks of your motor cortex. In this case, it was pretty easy, but they wanted to have it anyway. So the right hand motor activation in green, as expected, and then the left hand motor as well. And when we did our language test, it was strongly left lateralized. So based on the fMRI, there was no reason why he couldn't access the lesions. But again, we talked about this before, but based on the DTI, he decided not to because there were some very important tracts that were really close to the lesions, like the corticospinal tract in white, and then the optic radiation there in white as well, and then the lesions you see in red. And then this is actually my last case. I'm like chugging through this. Everybody okay so far? Maybe I'm going too fast. No? Okay, good. So case 3 is an 18-year-old history of seizures, no focal neuropsychological deficit. There was this, on the FLAIR image on the left and the T1 coronals on the right, the red arrow shows there's an area of T2 hyperintensity, right? Somewhere in the temporal lobe. Yeah? Anybody know where exactly in the temporal lobe that is? Or anyone? No? It's, you know, the temporal lobe, when you start from medial to lateral, you have your hippocampus, right? What's next to the hippocampus? Next to the hippocampus would be called parahippocampal, exactly. Easy name, parahippocampal gyrus. What's next to the parahippocampal gyrus? It kind of looks like, you know, it doesn't look like this, but that's why it's named for some reason. Fusiform gyrus. So that's your fusiform gyrus. And then after that, it's really easy to remember. Inferior temporal gyrus, middle temporal gyrus, and superior temporal gyrus. So the only one that doesn't make sense is a fusiform gyrus, which you just need to remember. So on coronal T2 weighted images, you see the fusiform gyrus. And then anybody know what so the fusiform gyrus is a really interesting area of the brain because that's the part of the brain that is responsible for object recognition, face recognition. So you look at me, and next time I see you, you would hopefully recognize me. And then that's the area of the brain that will light up, saying that, ooh, that's the guy that messed up the DTI lecture. Or if you see a cup, you know that it's a cup because that area of the brain is lighting up, okay? So there's a lesion here in the fusiform gyrus, the 3 arrows here showing basically just front to back of the fusiform gyrus. So we did an fMRI because they wanted to know which side the language dominance was. I believe she was right-handed, and the lesion, unfortunately, is on the left side, right? Which means that if she's left-handed, then they're kind of stuck as to what they could do. When you look at the language activation, then on the left side of the brain, that blue arrow shows Broca's activation. And then more laterally, in the superior temporal gyrus, you see Wernicke's activation. And then coronal images show the Wernicke's activation on the left side, and there was absolutely nothing on the right side. So this person is strongly left lateralized. Not that much stuff going on the left. Strongly left lateralized, not that much stuff going on the opposite right side. But this is where it got kind of crazy. You see that blue thing? Yeah, where is that? Fusiform gyrus. Oh my goodness, there's a lesion in the fusiform gyrus on the left side, and now all the activation that you see is on the right side. So because there was a lesion in the fusiform gyrus, we actually specifically did a test that is, it's called an object naming task. So we show them pictures of things, and they're supposed to tell us what it is. And that's exactly what the fusiform gyrus is supposed to do. I mean, we didn't do face pictures, but at least, you know, we got the majority of what the fusiform gyrus is supposed to do. And it just beautifully showed that every activation for the fusiform gyrus was on the contralateral side. So we talked to the epileptologists, and then, you know, they were actually really happy with this because they tend to not order too many fMRIs for various reasons, but after this, I think they started ordering more. So you see that longitudinal activation along the fusiform gyrus on the right side, which is the yellow, and then the green doesn't show anything on the ipsilateral side. So they were very, very happy with this. So that's our clinical fMRI, what we do right now. The future, and this is the kind of stuff my research is on, but the future of fMRI presurgical mapping is resting state fMRI. So I don't know if you're familiar with this, but in this fMRI, you actually don't have the person do anything. They put them in the MR scanner, and then they're just kind of, you know, lying there, just like a regular anatomic sequence. And it turns out I can get information about your brain networks without you doing anything. I can tell you where your motor areas are, even when you don't move your hands. And it's because there turns out there's a natural fluctuation in blood flow to the brain that even when you're not doing anything, different areas of the brain that are related to each other tend to have this slow fluctuation together. So all your motor cortex, it tends to have this slow fluctuating up and down bold effect flow. And we can separate out these networks. So here's an arrow, but without a brain. This is a case of a lesion on the left side of the head, yeah? Yeah. And what this is showing is my task fMRI. So I told him to move your hand. And then resting state fMRI, where I didn't tell him to do anything. I just told him just stay in the scanner, don't do anything. And then you see yellow is the area of overlap. So it has very good overlap with my task fMRI. And another patient, this is a language test. So we did language, and that's in red. And I also did a resting state fMRI. So I just put the person in the scanner and said, just, if you want to sleep, go ahead and sleep. And I extracted this information afterwards. And the green areas show activation of the language areas that overlap pretty well. You see Broca in blue, right? Wernicke in purple, even the pre-SMA in orange. So I was able to get all this information without the person doing anything, and it only took like 6 minutes. And in 6 minutes, I can get motor, I can get language, I can get vision, I can get other networks like attention, executive control, and more, actually. So this is the future. I mean, people are trying to fine-tune this a little bit and then to make sure that this is clinically doable. I think for motor mapping, we're there yet. So if one of the barriers for you to do fMRI was that, too much equipment and we need to train the technologists and all that kind of stuff, just move to resting state fMRI, and then you can actually just extract this information afterwards. So in summary, fMRI is a valuable tool to aid in presurgical brain mapping, and yes, fMRI is awesome. All right, thank you very much.